All right, let's do a quick clinical update on scarlet fever.
Okay, here's our plan. We'll start with the etiology and epidemiology, then move to clinical features and diagnosis. After that, we'll cover management and infection control and wrap up with complications and prevention.
So, first up, the cause and spread of the illness.
So, what exactly is scarlet fever? Well, it's an acute disease, and it's mediated by an exotoxin. The culprit is group A beta-hemolytic streptococci, or GABS for short. And of course, the defining feature is that very characteristic rash.
The specific bacterium we're talking about is Streptococcus pyogenes. That's our group A Streptococcus. Now here's a key point. Not every strain causes it. Only the ones that produce specific erythrogenic exotoxins are responsible for the disease. When you're thinking about who gets this, it's most common in kids, usually between 5 and 15 years old. You'll see it most often in the winter and early spring. And as for how it spreads, it's through airborne respiratory droplets.
All right, let's shift gears to the clinical features and how we diagnose it.
The progression of the illness is pretty predictable. First, there's an incubation period of about 1 to 4 days. Then, you get a sudden onset of fever and a sore throat. The rash usually appears 12 to 48 hours after that, and by week 2, you can expect the skin to start peeling. That's the desquamation.
Now, about that classic rash, it has a very distinct sandpaper-like texture. It typically starts on the neck, then spreads to the trunk and limbs, but here's a key detail. It spares the palms and soles. On darker skin tones, that texture might be easier to feel than the redness is to see. Also, look for pasteous lines, which are these petechial streaks in the skin folds. Think the armpits and groin. When you look at the patient's face, there are 2 key signs to watch for. First, you'll see flushed red cheeks, but this contrasts with a very noticeable pale area right around the mouth. That's what we call circumoral pallor. And inside the mouth, the classic finding is the strawberry tongue. Initially, it might have a white coat, but that peels away to reveal a bright red surface with these prominent enlarged papillae. You'll also typically see an erythematous pharynx, often with exudate on the tonsils. So, to put it simply, the clinical diagnosis really comes down to a classic triad of symptoms. You've got the sore throat, the fever, and that sandpaper rash. If you see this combination, especially in a child, you should be thinking scarlet fever. Now, to confirm your clinical suspicion, you'll want to get a throat swab. You can either send it for culture or use a rapid antigen detection test to confirm the presence of group A strep.
Okay, so once you have a diagnosis, how do you manage it? Let's talk about treatment and infection control.
The management plan is pretty straightforward and has 3 main parts. 1, administer antibiotic therapy. 2, provide supportive care. And 3, implement good infection control measures. For antibiotics, the standard is a 10-day course. Your first-line choices are going to be penicillin V or amoxicillin. Now, if your patient has a penicillin allergy, you can turn to cephalosporins or macrolides instead. This is really important for infection control. The patient needs to be isolated for 24 hours after starting antibiotics. Once they've hit that 24-hour mark of effective therapy, they're no longer considered infectious.
All right, to round this out, let's talk about potential complications and how to prevent them.
Complications can be broken down into 2 main types, suppurative and non-suppurative. Let's start with the suppurative ones. These are caused by the direct spread of the bacteria. Think things like otitis media, peritonsillar or retropharyngeal abscess, sinusitis, and even pneumonia. Then you have the non-suppurative complications, which are immune-mediated and can be quite serious. This category includes acute rheumatic fever, which carries the risk of carditis, and post-streptococcal glomerulonephritis, which can lead to kidney damage. A much rarer possibility, but still on the list, is toxic shock syndrome. So what about prevention? Well, there's currently no vaccine available for group A strep. That means the single most effective preventative action we have is the prompt diagnosis and treatment of streptococcal infections. So let's just quickly recap the main points. The causative agent is group A beta-hemolytic streptococcus. Your typical patient is a child between 5 and 15. The key signs are that sandpaper rash and strawberry tongue. Treatment is a 10-day course of penicillin or amoxicillin, and prevention relies on good hand hygiene and isolation since there's no vaccine. And that's a wrap on our clinical update. I'll leave you with one final question to think about. We know that immunity to the exotoxin is strain-specific. So what does that imply about the potential for recurrence in a patient who's already had scarlet fever once?
The answer is yes. Recurrence of scarlet fever is possible if an individual is exposed to new toxin-producing strains. This is because there is no lasting immunity since different strains of Streptococcus pyogenes produce varied erythrogenic exotoxins.